It is very important to treat or prevent CAD because what happens is when CAD progresses, it can lead to coronary ischemia or the decrease in blood flow and oxygen to the myocardium or the heart muscle. So angina or chest pain. So this is something that we have to always take seriously, and we need to consider this whenever a patient is complaining of chest pain. So subjective data. A lot of the times patients will complain that it's some sort of a crushing chest pain. It's heavy, there's some pressure, there's some tightness, and oftentimes it is accompanied by nausea. So that can sometimes be present, and sometimes some patients won't complain about that, but that can be present in their complaint of chest pain. So when it comes to the location of chest pain, that can vary depending on the patient, but a lot of the times patients will complain of sternal pain, jaw pain, left arm pain, or sometimes chest pain that radiates to the left arm. Sometimes patients will also complain of infrascapular or back pain. And certain populations, especially females, diabetics, even elderly, their chest pain may not actually appear or have the same symptoms as other people. So they may complain about different symptoms, and we can call that atypical chest pain. So when somebody's complaining about chest pain, we also want to ask, what's the pattern? Is it constant? Does it come and go? Are there precipitating factors? So is there something making it worse? Is there something making it feel better? What's the duration? When did it start? How long has it been hurting? And again, what relieves it? Does it get better with rest, or does it stay the same regardless of physical activity? So those are very important information to ask from our patients who are complaining of chest pain. When it comes to chest pain, you will often hear stable angina pectoris. So stable angina pectoris is basically temporary, and oftentimes it is reversible and usually has the same pattern. So it's very predictable. It's usually caused by coronary ischemia, usually brought on by a trigger. For example, exercise, smoking, sex, use of stimulants such as cocaine, and anemia. So there's usually a cause or a trigger for it. Also, the pain generally subsides once the precipitating factor or the cause is eliminated. So let's say if it's exercise, right? So once the patient stops exercising or stops the activity that triggered the chest pain, angina pectoris or stable angina pectoris, usually the symptoms will disappear once that patient stops that activity. Usually treated medically with medication, and we anticipate and control the trigger. So most patients, so if this is not a first time incident, most patients already know what are their triggers. So a good educational piece is to really determining the pattern, the triggers, and avoiding those activities that can lead to chest pain. Prinzmetal's or variant angina, also known as vasospastic angina, what's happening is that the coronary artery is spasming due to exposure to cold weather and sometimes stress. It is caused by vasospasms, which can cause coronary ischemia. It is often seen with other vascular diagnoses such as migraines, Raynaud's. Just FYI, treatments for Raynaud's a lot of the times includes CCBs or calcium channel blockers. The first line of treatment, again, is calcium channel blockers and nitrates. So with Prinzmetal or variant angina, sometimes although it's transient or it's temporary, it can often still show some ST elevation that over time goes away. So we talked about the stable angina, and we also talked about the variant angina. Next, we're going to talk about unstable angina or USA. Unstable angina, basically the pain increases in severity. So due to the coronary artery atherosclerosis or hardening or narrowing of the arteries, or plaque rupture, the new onset of intense or severe pain, and it happens even at rest, and usually it's unpredictable. So there's really no pattern in comparison to stable angina. Most of the time, stable angina patients know the triggers. With unstable angina, there's not necessarily a trigger. It just happens. There's no pattern. It's not predictable. So unstable angina is considered an emergency. Therefore, it requires emergent treatment. What is the treatment for unstable angina? So this is something that you have to remember from now on. MONA is a treatment for unstable angina. What does MONA stand for? So M stands for morphine, O, oxygen, N, nitrate, and A, aspirin. So unstable angina oftentimes is equivalent to a myocardial infarction. So sometimes that can be used interchangeably, and the treatments are basically, the emergent treatment is basically the same. So immediate treatment for MI and or unstable angina is MONA. M, morphine, O, oxygen, N, nitroglycerin, A, ASA or aspirin, and or Plavix. So morphine is given in unstable angina. Morphine is an opiate or narcotic. It's the drug of choice for myocardial pain. Why is it the drug of choice for myocardial pain? It has its benefits or the effects that we want to happen. So 1, it decreases the myocardial oxygen demand. 2, it decreases pain. 3, it decreases anxiety. And a couple of things that we have to remember when it comes to morphine side effects, and definitely we have to monitor. So these are the side effects. It does have a tendency to decrease blood pressure, and it can also decrease the respiratory rate because morphine can cause respiratory depression. Again, as we talked about earlier, oxygen is also a treatment for unstable angina and MI. So oxygen is a given. We're basically giving a supplemental oxygenation to the patient. Nitrate. So nitrate is given because of vasodilation. So that's what we want it to do, especially if there's some narrowing or vasospasming. We want that vasodilatory effect of nitrates. The common medication given is nitrostat or nitroglycerin tablet sublingual. So this is something that you have to remember. Common side effects of nitrates or nitroglycerin sublingual is decreased blood pressure and headaches. So these are some things that we have to warn our patients about, and at the same time we have to monitor before and after administering the medication. And last but not the least, aspirin. So aspirin, as we talked about previously, it's a platelet aggregation inhibitor, and it's also classified as NSAID or non-steroidal anti-inflammatory. For continued treatment of unstable angina or MI, for acute pain management, we can continue to give morphine, and then we also continue vasodilation with nitrates. So we have the short-acting, which is the nitrostat or nitroglycerin tablet sublingual. Again, the common side effect is headaches due to the increased blood flow and vasodilation. Then we also have the long-acting nitrate. An example of it would be Imdor or isosorbide mononitrate. Again, a long-acting nitrate that we administer in this patient would be Imdor or isosorbide mononitrate. We also have the topical nitrates, which is commonly Nitroder or Nitrobid. So that's a transdermal patch, and then the Nitrobid is a transdermal ointment. Something to remember with this topical nitrates is that it's important to know where the previous one was administered, and it's important to remove the old ointment before the new ointment is applied, just because sometimes then we can overdose the patient, right, with that. And make sure we look for other patches prior to applying the new patch. And also avoid accidentally applying it on yourself, because then you can actually experience the side effects or even the effects like hypotension, and also you can experience some headaches. There are also sublingual sprays, and sometimes when needed, there are continuous IV infusions of nitrates. Again, we also continue to give patients platelet aggregation inhibitors such as aspirin, and beta blockers are also given. So examples of those are atenolol, metoprolol, and propranolol. So keep in mind that beta blockers, especially propranolol, it can cause bradycardia. So it is very important to teach our patients that they need to check their pulse and of course blood pressure prior to taking the medication, as you know, if they start with a lower blood pressure or lower heart rate, that can make it even worse. Another treatment for unstable angina would be calcium channel blockers. So examples of those would be Norvasc or amlodipine, and cardizem or diltiazem. So if for some reasons all our interventions are not effective, the patient continues to be symptomatic, then we proceed, or basically the providers or doctors will decide to most likely do a cardiac intervention. So cardiac intervention or percutaneous coronary intervention or PCI. And then if unsuccessful, if there's an occlusion and for some reason they're unable to open the vessel, then the ultimate or last resort would be surgery. So angioplasty, that's a procedure wherein they use a catheter to place a stent that opens the blood vessels of the heart that have been narrowed by the plaque or buildup. So labs for unstable angina, we do check our cardiac enzymes. So examples would be your CKMB and troponins. We also check the CBCs or hemogram, and the homocysteine and CRP. As we discussed previously, homocysteine basically are amino acids in blood, mostly from eating meat, and according to some studies, increased levels are linked to early development of heart disease. Meanwhile, CRP, as we talked about earlier, is an inflammatory marker or C-reactive protein produced by the liver in response to inflammation. So nursing actions or nursing interventions for patients experiencing unstable angina. One, again, as mentioned earlier, is pain control and using relieving factors and using the following treatment, MONA, right? Something you have to remember. In addition to that, again, emphasizing patient education, we have to educate pertaining the disease process, risk factors, compliance, and potential outcomes. It is also very important to educate the patient regarding treatment, preparation prior to procedures, or preparation when it comes to medical or interventional management of the condition. And a very important educational piece is to educate our patients when to call 911. Again, what do we tell our patients? Time is basically your heart cells. So the longer you wait, the more likelihood of cell death. So it is very important to tell them that if they're experiencing the symptoms, to call 911 so that they can be taken to the nearest emergency department for immediate treatment.